Most people think about healthcare, they picture hospitals, doctors, and the rising costs of medical treatment. But in Singapore, healthcare is more than just a sector. It's a carefully engineered financial system. This system is designed to generate a surplus, not simply to provide care. Through mechanisms like MediSave, MediShield Life, and integrated shield plans, Singapore's approach ensures persistent positive cash flow and high reserves. However, this stability comes at a cost. Financial and timing risk are systematically shifted onto households. While the state enjoys fiscal predictability and strong reserves, individuals face growing unpredictability, silent rationing, and unequal outcomes. Understanding this surplus-generating architecture is key to grasping why Singapore's healthcare system feels both efficient and, at times, anxiety-inducing for its citizens. Let's explore how this unique model shapes everyday experiences and the broader social compact. The heart of Singapore's healthcare financing is forced saving. MediSave isn't just a suggestion to save for future health needs, it's a mandatory levy deducted from wages and locked away under strict conditions. This ensures the system always has liquidity, but it also means households may struggle with access and flexibility even as their balances grow. Layered on top is MediShield Life, a compulsory insurance scheme. Like traditional insurance, MediShield Life premiums rise regardless of claims, and coverage remains partial. The risk isn't pooled away, it's retained at the household level. Integrated shield plans meant as optional upgrades have become almost necessary for many, yet they repackage risk at higher costs and introduce new uncertainties. The result, a system that appears protective on paper but often leaves individuals exposed to unpredictable expenses and self-rationing. This financial discipline preserves the state's surplus, but can erode trust and security for ordinary citizens. Despite universal enrollment, Singapore's healthcare system produces unequal outcomes. Rationing doesn't happen through outright denial, but through waiting times, administrative thresholds, and cost exposure. When insurance protection weakens or becomes unaffordable, patients often delay care, migrate from private to public hospitals, and face longer queues. Those with more resources can bypass these barriers, while others experience fragmented treatment and uncertainty. Silent rationing mirrors income distribution, making inequality harder to detect and address. The middle class in particular feels the squeeze, paying full premiums, receiving limited subsidies, and carrying the heaviest financial burden. Over time, these pressures erode trust in the system, turning what was once a model of efficiency into a source of anxiety and political risk. The challenge now is to decide, should risk remain individualized or should the system move towards greater social assurance and shared protection? Book argues that Singapore's healthcare system must evolve from insurance-led discipline to assurance-based predictability. This doesn't mean free healthcare, but rather using accumulated surpluses to cap out-of-pocket costs, stabilize premiums, and guarantee timely access. By shifting discipline from patients to providers and planners, and by investing directly in capacity, the system can restore trust and renew the social compact. Surplus should serve as a buffer and a commitment device, not just a symbol of prudence. If the choice to reform is deferred, inequality and anxiety will quietly grow. But if predictability and shared risk are prioritized, stability will shift from balance sheets to lived experience, ensuring that sustainability means not just endurance but lifelong trust in the system. The future of Singapore's healthcare depends on whether discipline remains an end in itself or becomes a means to shared security.